I don't have the list of people, but I could pretend I'm Dr. Rodriguez and take the role. Dr. Rodriguez isn't here. I am. So Dr. Cheek,
Present.
Dr. Mercer,
Present.
Dr. Shin.
Present.
Now let's see, is Kobe Cole.
Present.
He's our IT person who's.
Yeah, I thought he was a staff person, but I can't see him. So
You're visible thanks to his skills, so.
but I'm glad you're there. And I know Norman Eubanks is our IT person. Frederick Dobard is probably works for you too.
He does. He's awesome. Yeah.
And does Jeffrey Rickman.
I'm going to, if he's not on already, I'll be introducing him.
Yeah, he's there. He's not there. He's not there visually, but he's there by name.
Okay.
So there he is.
Yeah.
So I believe we have no other board members there. But
There he is.
the roll call is called. So Dr. Toomey, you're on.
No, thank you so much. I just have some very, very brief opening remarks. We are in the legislative session. This is a really unusual legislative session for those of you like Dr. Cheek, who's been around. I just saw Rick Ward this morning. It has been kind of accelerated because of the schedule that they chose, but we only got the House budget the day we had to testify to the Senate about the House budget. And so it's been really kind of unusual. And so we're kind of on pins and needles to see what will happen. And so I don't want to speak too soon about what is happening, because I think it's still unclear. And there's 2 weeks in a very kind of volatile session. So we'll see it. And Megan will be talking more about that. But in the midst of all this, we've been joined by Mr. Jeff Rickman. We're just delighted. He's joined us as our general counsel. And I asked him just to step in and say a few words, but Mr. Rickman has held many, many positions, both in the private sector law, but also in government, including at DCH, where among other positions, he was over the state health benefit plan. And then he followed Commissioner Clyde Reese when he became a judge and worked in his office. And Judge Reese recently passed away, and we were able to recruit him to public health to join us. So we're just delighted that you're with us, and thanks for joining us today just to say hello to our board.
Yes, thank you so much, Dr. Toomey. And I'm thrilled to be with DPH. And as Dr. Toomey said, I was with the state for several years and took a small break to the court system, and I'm just thrilled to be back. I look forward to meeting everybody and to working with everyone, and really happy to be back in the state, and certainly happy to be at DPH.
Well, I know one of your jobs is to keep the department and Dr. Toomey out of jail. But
It's a harder job than you know.
but the law is extremely important for public health, as we'll hear when we get the legislative update. But legislation and regulation are some of the key factors in improving the public health of populations, and need to be renewed just as banking regulations do. So we look forward to your professionalism, and thanks so much.
Sure, thank you.
And the only other comment I have for those of you who are aficionados of public health history, Mr. Hopper isn't here today. I'm sorry he's not, but I'm sure that there's a lot of action because they just opened up a new outpatient surgery center, which was much needed. They often had to cancel elective surgeries because of the trauma coming in. The site of that new Correll building used to be the office of the Fulton County Health Department. for many years. And I had the displeasure of being there and moving the Fulton County Health Department to its new location. But it made 2 Peachtree Street look like a resort, and that pretty much sums it up. So with that, let me turn it over to Megan.
Hey everyone, Megan Andrews here, Assistant Commissioner for Policy. I am going to provide you guys some quick updates on legislative session, specifically looking at the bills that we are keeping an eye on that are still alive and have some direct impact on our agency, meaning we're going to have to do something differently if they pass. So you can go to the first slide. So House Bill 196 is updates to the Georgia Access to Medical Cannabis Commission. This bill does add 2 conditions as qualifying for participation in the low THC oil program, which some of you may know our office is responsible for maintaining that registry and issuing cards. But we will have to update our rules and regulations regarding those new conditions if this bill does receive final passage. It's currently awaiting a vote in Senate committee. Next slide. House Bill 416 is legislation to allow qualified pharmacy techs to administer vaccines to adults. They do still have to operate under the authority of a supervising pharmacist who is available and on site while the vaccines are being administered. This just expands the access to vaccinations through pharmacies. And it is awaiting a vote in Senate committee. Next slide. The next bill is House Bill 440. It allows schools to stock a supply of glucagon in the school setting for medical professionals to utilize. It does require DOE to consult with our team to develop the rules and regulations on implementing this new program. So we would be involved in that, and it is awaiting a vote on the Senate floor. And these are all updates as of Thursday last week when I made these slides. So there may be a few changes. The next one is House Resolution 185. This is a study committee on healthy food in retail settings. Obviously, this is something that we would be interested and involved in, particularly through our WIC program, which promotes access to healthy food for qualified families. And this resolution is awaiting a vote in House committee. Next slide. Senate Bill 3 is an attempt to reduce requirements for employment in state agencies. So it does have agencies look at qualifications for employment within our department, and where practicable, reduce those requirements that require a 4-year degree to hopefully increase workforce. And that bill is awaiting a vote on the House floor. Next slide. Senate Bill 45 is regarding seizure action plans in schools. It provides a process for parents who have children with epilepsy or seizure disorders to receive support from the school system for the student while they're attending classes or extracurriculars. This would impact any of our public health staff that are assigned to serve as the school nurses at the local level. So we are keeping an eye on that and will assist in any rollout as necessary. And that one is waiting for a vote in House committee. Next slide. Senate Bill 46 is related to prenatal testing requirements. I think we've given you presentations in the past about updates that we've made to our prenatal testing requirements through regulation to bring some consistency with CDC recommendations as far as adding Hep B or expanding Hep B testing and then adding Hep C. This was last summer, I believe. And it came up during that time that there was an exception to syphilis testing at delivery. And in discussions with some of the provider groups like MAG and conversations on those regulations, kind of brought forth this bill that's being pursued by one of the advocates. So this will require HIV and syphilis testing at 3 times during pregnancy, the first prenatal visit, 28 to 32 weeks, and then at delivery. And this bill is awaiting a vote on the House floor, and I believe it is scheduled to be voted on tomorrow. Next slide. Senate Bill 47 is our agency bill that we're pursuing this year. This legislation updates the Smoke-Free Air Act to bring parity to vaping and traditional tobacco smoking. So when this bill originally passed, vaping was not anything that was available at the time. So this just brings consistency and prohibits vaping anywhere where you can't smoke a traditional cigarette. This bill is awaiting a vote in the House Public Health Committee. Next slide. Senate Bill 55. It was amended on the Senate side. It prohibits regulation on any business owned by someone under 18. There was a lot of conversation about potential unintended consequences in the way it was originally drafted, and a lot of individuals came forward to develop some language that reduced those concerns as far as one of the items that came up was, could a 17-year-old open a tattoo shop without regulation? And so this new language closes some of those loopholes, and it is awaiting a vote in House committee. Next slide. Senate Bill 64 is going to require some changes in our Vital Records Office as far as the issuance of birth certificates. So it allows for our Office of Vital Records to issue an original birth certificate to adults who were adopted. Right now, they can access that original birth certificate, but it has to be court ordered. So this creates a process for them to get it as long as they're over 18. We will need to do some IT upgrades at our Vital Records Office in order to facilitate this process, but we are awaiting a vote in House committee on that. Next slide. Senate Bill 107 is Izzy's law. It stemmed from a drowning incident that happened over in Augusta last summer at a swim lesson. It has DPH develop and make available on our website a model aquatic safety plan for private swim instructors. And this is to be based on national standards that have already been developed as far as best practices for swim lessons. It does allow us to partner with other external organizations to develop these model plans, and does require an annual update if any changes were made to nationwide best practice standards. That bill is awaiting a vote in House committee. Next slide. Senate Bill 177 is the Food Insecurity Eradication Act. It creates a council within the Department of Ag to look at food insecurity and address ways to address that problem. DPH would have a seat on this council, and one of the items that they are tasked with looking at is solutions to improve the WIC program to end food insecurity. So we'll be helping implement that one if it passes. And last one is Senate Bill 197. This is Healthcare Practitioners Truth and Transparency Act. In any sort of clinical setting under this bill where there's an APRN or a PA who also has a doctorate degree, this bill would require them to specify their education to the patient in that setting and inform them that they are not in fact a medical physician. That bill, and we do have a handful of APRNs down at the local level. So this bill is awaiting a vote in House committee. And I'm sorry for the rapid fire of bills, but it's a short synopsis of everything we're kind of keeping an eye on that will require some action from us if these bills receive final passage. And I'm available to answer any questions.
Actually, not
Meg-
everything.
Megan, can you maybe anticipate which bills will pass?
Oh,
I think vaping will pass.
I hope vaping will pass. That one, it almost made it last year. I think that syphilis testing one will probably pass. It's up for a floor vote tomorrow, and there were no changes to the substitute, so it doesn't need to go over for a Senate agree. So I think, tomorrow, as long as there's no floor amendments, that one's kind of a done deal going to the governor's office for signature. I can't really say for the rest. I feel like this, I never like to predict what's going to happen during session because I'm always surprised. So we're preparing for all of these. I'll say that.
Okay.
Any other comments or questions? Megan, you've been quite busy. And I also
Just a little
like to recognize that Mr. Walker has joined us, so for the quorum as well. Welcome, Mr. Walker.
Thank you. Sorry, I had a prior speaking engagement and I just tried to get here as quickly as possible, but thank you. Happy to be with you.
Any other comments or questions other than mine?
Can I just say, and I'm sure many of you know this already, but crossover day is the day that we wait for the bills to pass one house and then they can be heard in the next. But that doesn't mean they're dead forever. They can be attached like a Christmas tree ornament onto other bills and show up. And so nothing is dead till it's over. And so some of the kind of problematic bills that sort of disappeared could reappear in a new form attached to must pass legislation. So we're really kind of on pins and needles waiting for this to be over.
Yes. I like to refer to those as zombie bills. They come
Zombie
back
bills.
from the crossover day.
So given the uncertainty of which ornaments will get actually put on the tree, I'll make some comments and ask questions as if all of them might. So first of all, I think it's really terrific that the pharmaceutical vaccine issue is added. That has been very crucial during COVID, and it will be really crucial for all vaccines.
Right.
And similarly with HIV and syphilis testing. My questions are in order. First of all, about what's the definition of low cannabis oil? What does low mean? Second question is, assuming that glucagon is being used for severe hypoglycemia with insulin,
Right.
how do you decide who needs it and who doesn't? And how does that get done? I can understand administering it, but the question is who gets it? And then the third question, I'm giving you all at once, is how do we feel about this workforce education reduction? I'm fairly concerned that some of the, and not just because I work for a university, but some of the jobs could get dumbed down just to meet the money available.
So for your first question on low THC definition, I'm actually going to toss it to my colleague Xavier, who oversees that program, to provide that info to you.
Good afternoon. So what qualifies as low THC oil is 20 fluid ounces or less currently.
And what percentage THC?
I think it's
It's pretty high. I mean, it's
5%
5%.
5%.
Yeah, I was gonna say our
5% or less.
compared to other states, our low THC is pretty high.
And I knew it was 5%, but I wasn't sure if this was some special oil that's even lower than 5%, because 5% is not really low.
No, exactly. That's what we were saying the other day.
And then your question about the school glucagon prescriptions. So this legislation would follow the diabetes action plans for students. So similar to how I mentioned the seizure action plans that parents in conjunction with the student's healthcare provider could submit action plans to the school on, hey, here's what you do in these circumstances. This is another resource in the school's tool belt that they could use for those incidents where there's a student with diabetes. And the school action plans already have that language in there that schools can administer emergency medications as necessary. This just allows the school to have that medication on site and stock it themselves. Kind of, I think there's something similar with albuterol in schools, allows them to have a stock of albuterol. And then your last question about the employment and the education item. This is something that would apply across state agencies. So I anticipate it would probably be a review conducted by the State Personnel Board or the Department of Administrative Services that oversee personnel across all state agencies for them to take a look at their standards for various positions within state government.
See, I think I would feel more comfortable if it was a question of looking at all the classifications for either increasing or decreasing the requirements. But when it comes across as what we want to do is decrease the requirements throughout the state, that may provide some opportunities for other people, but the general public doesn't see government agencies as being filled with overqualified people. And I'm more concerned that we aren't forced to provide too few professional requirements for people in public health.
I think that's a great point. Yeah.
Anyway,
No, I appreciate that.
that's what I think. Anyway,
No, spoken as a former dean of a school of public health. I
Yeah,
just
right.
want to note.
well, I don't just mean
No,
that
I'm just
they have
teasing you
public
because
health degrees, but you don't
No.
want people to be underqualified.
no, exactly. And the trouble is underqualified and underpaid even at that.
That's right.
So,
And particularly if the qualifications are being reduced to fit the budget.
exactly, yeah.
Thank you, Megan. That was terrific.
Yep, absolutely. Thanks, guys.
All right, next slide. Good afternoon. So we are going to be presenting on the Alzheimer's and dementia-related disease program here in Georgia. My name is Xavier Crockett. I am the Director of Health Protection.
Hi, everyone. My name is Elizabeth Head. I'm the Deputy Director for Injury Prevention and the Program Manager for BOLD.
Next slide.
All right, everyone, we're going to dive into just a little bit of data so we can have some context on this and our problem of dementia. All the numbers you see in front of you are specific to Georgia, most of which are taken from the Behavioral Risk Factor Surveillance Survey. So in 2018, there were over 140,000 individuals in Georgia living with Alzheimer's disease or dementia. That number is projected to be 190,000 or more by 2025. As everyone knows, we have a population in Georgia of getting close to 11 million, I believe, and about 1.4 of those are over the age of 65. Specifically within the BRFSS, we look at two different things. One is caregiver support, which is an entirely different optional module. However, we also look at cognitive impairment. So there were 385,000 individuals with self-reported cognitive impairment on our BRFSS survey, and yet 80% had not yet been evaluated or treated. Really leads us to the need for a complete system of care before, during, and after diagnosis. Right now, there's generally a 6-year delay in memory loss diagnoses, and often folks are misdiagnosed with different types of dementia before they get to the correct diagnosis. And of course, all of this is extremely expensive. Next slide.
So we are tackling this problem with the BOLD grant, which is building our largest dementia infrastructure, not our acronym as CDCs. But we're simply put, expanding access in rural Georgia, increasing visibility of this issue, and making sure that we educate our partners. And one of the ways that we are also tackling this is our acronym is Be Seen. We're using the BOLD grant to provide that systemic education across all of our partners and networks, evidence-based, and bringing all of our partners into the network to understand this issue, particularly in rural Georgia, because we know there is a lack of healthcare access. We're hoping to bring, we're bringing public health into this systematic approach to Alzheimer's and dementia-related diseases by reducing the risk to our dementia residents here in Georgia, early detection and access, but also supporting our caregivers, the ones who are actually doing the day-to-day work with these residents. And then one of the most important things is educating our professionals across all networks. Next slide.
All of the work that we do in BOLD here in Georgia and any BOLD funded state happens through the Centers for Disease Control's Healthy Brain Initiative. The Healthy Brain Initiative roadmap uses the MAP actions that you see here. Our Georgia BOLD team is utilizing a public health approach to dementia and Alzheimer's disease through these different MAP actions. So we work on education and prevention by employing the actions of the roadmap under the educate and empower activities, for example. We obviously support our partners on a regular basis, but we're also working hard behind the scenes to craft workflows that are needed in public health to more specifically support the paths to diagnosis, which we will talk about in a later slide. We're working hard to assure a competent workforce through training on the basics of dementia for a public health workforce, and then partnering to implement appropriate policies that keep this vulnerable population at the forefront of planning. We're particularly adept at monitoring and evaluating. Our robust DPH epidemiology team, our IPP program team, and other partners are pushing forward with new and innovative ways to make much needed data accessible and connected. We're going to take a look at each one of these roadmap actions on the next slides. So first, let's talk about the Think About It campaign. Really, this Think About It campaign, which was created by our DPH communications campaign, kicked off the efforts here for public health in Georgia. Georgia legislature, thanks to the advocacy of the Alzheimer's Association Georgia chapter, provided DPH with funding. Our communications department did what they do and made an incredible series of MAP messages for the public and for professionals. Our next efforts are to take these messages, all of which still exist, and incorporate brain health into chronic disease self-management. If you're taking care of your heart health, you're taking care of your brain health. Incorporate it into falls prevention. When we're addressing gait and balance issues, we're also helping our brain. Thinking about driver safety. If you're not behind the wheel, there are ways to be mobile. If you are behind the wheel, you really do have to pay attention to those extremely subtle changes. We're going to take a look at those on the next slides. So our next slide, we have one of our first graphics. This is lost. Did you forget your way to the grocery store again? This isn't about going and being, just inundated with all the things we have on our plate. This is getting lost going to routine things. And so that is something we want someone to think about it and talk to the doctors, just kind of hearkening back to that 80% of people with cognitive decline are not talking to their physicians. Next slide. If you're having trouble making the numbers add up again, we want folks to think about it. If you've always been good at a budget and suddenly you're not, that's a thing to consider. Sometimes it's stress, sometimes it's not. Next slide. I think this is probably one of the most important and poignant of the different available graphics. This is obviously about not finding the right word, but it's more than that. Do you notice yourself or your loved ones having trouble connecting the relationship changes that happen over the course of these diseases? And of course, as these diseases progress, all of this changes yet again. So this is a really lovely way to open the door and have these conversations with our partners and with the public in general in Georgia. Next slide. Everyone knows that we are a largely rural state. We're very proud of our partnership with the University of Georgia. Go Dogs. Stakeholder mapping, they started out their work engaging local leadership in a very specific way. We're not coming in with capes and talking about how we're going to make some changes. We want to know what information the local community wants to know, how they want to receive their information, and how and who they want to lead their local efforts. So UGA has done a phenomenal job in mapping all of this. They're actually in 8 communities right now with plans to further expand. While they're doing all of that in rural roads with no phone access, they're also having created 2 different educational formats, brain health and risk reduction. Those are going into the Osher Lifelong Learning Institutes because those adult learners that participate in OLLI are the ones that are not only managing chronic conditions themselves, but also caring for others that are on this road of these diseases. Finally, the Archway Partnership, which is the socioeconomic arm. We're really proud that the approach that UGA has taken here is that Archway works locally to say, hey, folks, what do you want to do? And with these loosely created local collaboratives, these Archway partnerships are providing formal structure for them, which really breeds sustainability and helps get us to where we want to be long-term with expanding this into all of our rural counties. Next slide.
So how are we leveraging these partnerships to expand access? We're using a telehealth model in our local health districts, and we're collaborating and partnering with the Georgia Memory Net. And to give you guys an overarching view of this, we have tablets and 2 of our health departments right now. We're looking to expand more, but basically, someone presents themselves or someone has been referred to our health department when they come in and they are assessed by a Georgia Memory Net professional. And there's a battery of psychometric testing, including a very in-depth memory test, as well as a letter and category fluency test, among others.
Yeah, so these workflows, creating these workflows behind the scenes were really important. One of the things that is amazing about the dementia and Alzheimer's disease work here in Georgia is that the rest of the country is looking to us. They're looking to us for how this goes because it's simply not been done before. There are no protocols. There are no workflows in the background about how we connect community and clinical linkages, and we're making those happen. So this is a Georgia Memory Net patient that is being seen locally instead of having to drive to one of the 5 memory assessment clinics because we have the telehealth infrastructure that we do at our local health departments, which is very exciting. Next slide. As Xavier said, our 2 pilot sites were Emmanuel County and Dooley County. It took us about a year to get the workflows correct. Each patient that goes in has a private room. We have done tabletop exercises and remote planning for all of this. We had to create scheduling processes in the background, how that's going to happen, what are the different ways in which a patient could end up at a memory assessment appointment, but still be at our public health departments. We are extremely excited and proud that our first 3 patients have been scheduled, and the first 2 of those 3 visits have happened. So now that they're real, our nurse managers in those locations they're just ready. They want all the patients right now to come into their health departments. And so they're really ramping up their efforts on these different visits and what we can do.
And our goal here is to expand across the state to other health departments, as well as bring on partnerships like our federally qualified health centers that often see the underinsured and uninsured, as well as some of those other other government agencies that we regularly partner with that deals with those 65+ communities.
Next slide. So BOLD is a complete package across all of those roadmap actions. And so we would be remiss if we did not speak briefly about caregiver support. The thing about care partners is that they are hungry. They want knowledge and information. They know that they are struggling. They know that they need some help, but they don't know what. And so we have brought through public health Savvy Caregiver, which is an evidence-based program. A trained leader takes individuals through 6 weeks of caregiving issues, both directed at issues you may face as a caregiver while caring for your loved one, but also turning it inward in the care that you need to provide for yourself as a caregiver. As people are completing this program, which is phenomenal, they are also looking at what's next. Emory is currently testing telesavvy, which would allow folks to do this program at home. The benefit of the small group is somewhat lessened, but the study is showing some positive results with telesavvy as well. Powerful tools for caregivers have been, it's a longstanding, well-known program implemented through our area agencies on aging. As departments of public health, we want to be able to tell our citizens that they could go to any of their AAAs and also do powerful tools for caregivers. Our goal here is no wrong door. No wrong door for community resources, no wrong door for access to services. We're also particularly excited about our faith-based program efforts. There is a program called Alter out of Emory, led by Dr. Fayron Epps. The goal here is to specifically reach African-American faith-based churches. They start by having those churches become dementia-friendly. When you gain the dementia-friendly status, they are then treating it very much like UGA is in terms of creating almost a local collaborative within that church. What else do you want to know about? How would you like to know about it? And so they've been able to go in and teach risk reduction, brain health messaging, work with them on managing chronic conditions for themselves and the loved one that they're caring for. It's incredibly exciting.
And so dementia-friendly status, the definition of that is basically where people with dementia-related diseases are supported and respected in their physical environments, a safe space for those who are progressing through these diseases. And so one of the highlights of the dementia-friendly status is that the DeKalb County is the first county in Georgia to have their entire county as a dementia-friendly status county. The goal here is to work with our health departments, our cities, and our counties to have more of those come on board as dementia-friendly counties. We think it is very important, and it shows the right message that we are looking, we're looking to support this community.
Next slide. We're almost done, friends. Workforce development. We'd be remiss if we didn't talk about professionals currently in the field. BOLD is all about bringing public health into the umbrella that is dementia and Alzheimer's and aging. And so we've worked to create through the online learning system that's part of our Office of EMS and Trauma, TRAIN. There's now a 4-part series where public health professionals and emergency responders can take that and receive CEUs for it. I think it's live later this week. So that is sort of an intro step where folks can get credit for doing this education. We also are looking in our communities to do something called a virtual dementia tour. That's through a nonprofit called Second Wind Dreams. And you go and experience just 5 minutes of a day in the life of someone who is challenged in their daily activities of living by dementia or Alzheimer's disease. Then you debrief. We're combining that with additional meetings with professionals to say, how now that you have an understanding, are you going to implement this into your daily work? How can you change your policies or your work practices to incorporate this population? All of this is thanks to our wonderful workforce development efforts through GARD and through Emory. And what I think I'm most proud of here is that some of our public health schools are working to cross-post with the schools and institutes of gerontology in the state. GSU is our first one to do this. And they are working so that public health professionals can also purposefully look and take classes for the adult range of issues that happen as we age, as opposed to having to seek it out. Next slide. Finally, data and monitoring. This website, OASIS, is familiar to everyone. The Office of Health Indicators and Planning and our EPI team have worked with us to create an Alzheimer's disease and related dementia dashboard. It's circled in red on the screen. That dashboard at this moment takes you to the hospitalizations, deaths, and ER visits specific to the ICD-10 codes related to any type of dementia. What will happen next is our aggregate analyses from the BRFSS modules that we have on caregiving and cognitive impairment will then go up on the dashboard. The next step after that is to include the Alzheimer's disease and related dementia registry data. That process is probably 4 to 5 years down the road, but we are just so proud of the partnership we have with EPI and with OHIP to be able to make that happen for professionals and citizens in the state. Next slide.
All right. Thank you guys for listening. You guys have any questions?
Well, thanks, Mr. Crockett and Ms. Head. Are there any comments or questions from the board?
That's an excellent presentation and exciting news.
Yeah, I concur. Thank you for your presentation. And my question is, I think initially there was some question about that we are under screening for dementia. So is there a specific program for more robust screening?
So the telehealth program that we have in 2 health departments currently, we are looking to expand that across the state where physicians, PCPs, hospitals, they will be able to refer to the health department where they will get that psychometric screening there with our Georgia Memory Net professionals. We are actively working to work with the healthcare community in rural Georgia to kind of boost up that screening process. And let them know that the health departments are there. We do have this process in place.
Okay, but these screenings are not mandatory. Is that right? It's a voluntary?
No, they are not mandatory.
Okay, thank you so much.
So I think this is terrific that you're paying attention and also putting something in place to deal with this problem, which because of the aging of the population is growing. And speaking as an aged person, I'd like to ask a couple questions about context and also scope.
Yeah.
You began by talking about how large the problem is and how large the underevaluated part of the problem is. So the scope issue is, how does this fit into the context of the size of the problem in Georgia? Now, and how do you continue to evaluate that? If 5 years from now you put the slide up and you have the 1.4 million and the 375,000, then the question is, how much of that apple have you bitten off? And the second part is context. I think that the health care for the elderly in the United States is a blight on our country. So that begins with my bias. It's very variable and often inadequate. And it came to spades when you looked at what happened with COVID, where initially 30% of the deaths in the country due to COVID were in understaffed, poorly managed, underpaid nursing homes and other facilities, where a lot of these people you're going to evaluate will end up. If they can afford it, they'll end up. And so the context is, say you screen several thousand people, what happens to the people that you screen who actually need medical care and help, and maybe they're uninsured or they're not quite eligible for Medicaid yet? Are you going to have that as part of the tracking and evaluation system?
Really excellent question, sir. Thank you for bringing them up. In terms of scope, one of the things that the rest of the country looks to Georgia on, and lots of states have this, our aging network as a whole talks about no wrong door. So there's some important pieces when we think about no wrong door. We want our public health professionals to understand the community and clinical resources available in their areas if someone asks. We also want multiple entry points into this sort of system of referral and care. If you talk to a care partner in Georgia, one wonderful lady named Sharon Hall among them, who's an advocate of, she just knows everybody. there's this really sad thing, to your point, about adios and diagnose. And so what we're looking to do is make sure that from the time we're looking at risk reduction, which really, quite frankly, we should be doing when we're addressing chronic diseases in our middle ages, right? All the way through to where we're starting to see cognitive impairment and some decline. And then suddenly there's a diagnosis of some sort. What is the care after that? It can't stop with a diagnosis. Yay, we've gotten to a finish line. It's not a finish line, it's a starting point. So that no wrong door means that along that entire continuum, there's both awareness from the community and from clinical sides about the available resources. And that is a set of professionals working through and across systems. We are doing constant QA to ensure that that works. Huge, lofty goals. We don't do anything small here. So what we're looking at is the entry point specifically for public health into what is really a beautifully established aging network here in Georgia. Our 12 area agencies on aging are well connected. We have a stunning partnership with the State Unit on Aging, both before the pandemic, through the pandemic, and now. We've done some very important strategic work on aligning our state plans so that we can have those synergies and grow those synergies. And what BOLD is allowing us to do is create these entry points for public health. So to your very specific and important point about screening, anybody in this room can be trained to do a mini cog. It's not a challenging test to do. What we don't want to happen is for everybody in the room to be doing mini cogs like you'd go talk to somebody at the grocery. There's no follow-up action there. And so when we are thinking through our workflows and the need for where public health intervenes or participates here is what happens next. It centers around the primary care physician where there is one, and then also our federally qualified health centers. There has to be a really specific link between those clinical pieces and community for this to work. So at the point in time where we're doing both the tablet project in all 159 counties, because we're ambitious, and we're expanding to where also public health clinics are able to do these screenings that you would do as part of a wellness visit. They have to be connected with a primary care physician. It's got to go back to that individual. And so what is fascinating to me is, I shouldn't be surprised, I grew up in a rural town. They all know each other. Our friends in Emmanuel County, they know all the docs that are there. They know where he goes to church, and they're going to talk to him about it on Sunday. So we have to trust those processes, but also document them somehow. Anything that we're doing with referring has got to go back to primary care, has got to go back to where people are seen. We're looking also at two very different populations, and this is probably not the day for it. 45 to 64, really much more on the risk reduction caregiver resource side. 65 plus, management and care resources post-diagnosis. So we're trying to look at those two large buckets and think through them strategically, you know, a bite of an elephant at a time.
Can I ask you a question?
Yes, ma'am.
For the AAAs?
Yes.
How old do you have to be to get services?
Yeah.
How old is aging?
So
Not that I have any interest in this.
no, much too young. Our area agencies on aging are not just for folks 65 and older. Any adult with disability, they're going to be able to tell you, because they have care service navigators that are specifically trained to get you in touch with the right resources. So you're looking at adults, probably 40, 45 if they have a disability, or really younger if they're an adult with a disability, all the way through the aging process.
And we're ensuring that that loop is closed, as she's mentioned.
Yeah.
That once we do that screening, that there is a referral process and a treatment plan, an assessment that goes back to their PCPs or to those clinics. And if they do not have a PCP, or if they do not know where they can get that, we are working with Georgia Memory Net to make sure that that process is in place.
Right, thank you.
I want to applaud you again for your enthusiasm, and then also throw a couple more,
Please.
blankets on the fire here.
Yeah.
One is that, you know, again, speaking as an aged person, there's a lot of reasons people don't get tested, and it takes Dr. Toomey and I back to the early days of testing for HIV, when there was simply nothing you could do about it if you were positive.
Yeah.
So having mild cognitive impairment is extremely stigmatizing, and it's not very convincing that you can do much to stop it, let alone even predict the frequency of it turning into Alzheimer's. But it's something that a lot of people just don't want to be tested for. So when Dr. Shin said, is this testing mandatory? That's a very controversial issue. And when you look at the people who haven't been tested, it's not simply a question of making the services available, but it's a question of identifying those things which can motivate people to be tested, and then what you're going to do about it if their test turns abnormal. A good friend of mine went to a private doctor in North Carolina last week, and he did some sort of test in his office and told her she had impairment and she needed to go see an Alzheimer's neurologist immediately. And what she did was call all her friends and cried. So, I mean, that's something to think about. The second thing is, for these very reasons, you need to scope out how common and in what places telemedicine is going to help. You had to think about a group of people that would be inadequately matched for telemedicine. It would be the elderly with mild cognitive impairment. I mean, they may not have access to the equipment. They may not know how to use the equipment. And also they may not know they're supposed to use the equipment. And so to me, telemedicine would, until proven otherwise, would be seen as a niche rather than as a big solution.
I couldn't agree more. The utilization of the Department of Public Health's telehealth system is really it's a little bit broader than, it's a little bit narrow than what it sounds like. We're using our physical DPH locations. We're using WebEx, which is HIPAA compliant and part of our telehealth system. It is simply a tablet in the room, and then it is a video call just like this, where the testing is done. And so even with that said, to your point, this is exactly the work that we're trying to do, is to figure out all of these pitfalls, because it's not a blanket coverage for everyone. And that stigma is truly, this is 10, 15 years worth of work that we're talking about.
I think you'll learn a lot that'll help a lot of people.
We're excited for it. Yes, sir.
Thank you. Environmental health.
Good afternoon, everyone. I'm going to go out on a limb here and make an assumption that you all have enjoyed dining at restaurants or staying in hotels or campgrounds and swimming in public swimming pools. If so, then there's an environmental health specialist somewhere that inspected those facilities to make sure that they were safe for you and your family. My name is Galen Baxter. I'm the State Environmental Health Director. And today I'm just going to give you a brief overview of environmental health, its structure, and I'm going to highlight one of the programs that we regulate, which is the body art establishments. Next slide. So currently we have 30 employees in our state office. We have 18 district environmental health directors, 7 regional lead coordinators who also work in our chemical hazards program. We have 12 district lead coordinators, and we have 504 environmental health positions across the state. But currently 55 of those positions are vacant. So it may seem like quite a bit of vacancy, and it is. However, I can say this, it's getting better. It's much better now than it was for the last 3 years. So that's a good thing. And so you can see, out of those 504 environmental health specialist positions, we're responsible for making sure that 34,000 food service establishments get inspected, 3,000 tourist accommodations, about 9,000 public swimming pools. And within the last year, since March of 2022, we've issued around 32,000 septic permits. Now you'll notice that second from the bottom there, the body art facility count, the current number is unknown. You'll find out why in just a moment as we get to that part. So,
Attractions.
all right. Next slide, please. All right, so here's a very broad overview of our structure. My team consists of a deputy environmental health director, the program directors and their program consultants, and then also the district environmental health directors. The local environmental health specialists work for the county boards of health, but the district environmental health directors oversee the work that are done in the counties. Next slide. So as you can imagine, to make this program successful entails shared responsibilities at all levels. So the state office essentially creates the rules and regulations for the mandated programs from OCGA. We interpret those rules and regulations. We provide training and technical assistance to the to the districts and to the counties, as well as the public. If we were a military organization, the district environmental health directors would be our sergeants. They're essentially the backbone of what we do. They work together with us as a team to help provide input with the rulemaking and implementation at the local level. They advise the county boards of health and they report the activities from the local environmental health specialists back to the state. The local environmental health specialists are the ones that are in the trenches day to day. They issue the permits, conduct inspections, they provide education and enforce the rules and regulations. Next slide. So as I mentioned before, there are certain programmatic mandates that we have through OCGA. And in addition to the ones that we've already discussed, environmental health is also responsible for portable sanitation, certifying septic tank contractors and septic tank pumpers, responsible also for rabies control, investigating complaints at tanning facilities. Next slide. And also monitoring and helping to mitigate factors that cause childhood lead poisoning in people's homes. Also conducting assessments and providing guidance for locations that are affected by chemical contamination, and conducting mosquito and other vector-borne surveillance, and providing public education on reducing mosquito breeding areas around their homes. Environmental health is also responsible for responding to and assisting with disaster recovery efforts and ensuring public health measures are in place at mass gatherings, such as having sufficient restrooms, clean drinking water, and safe food. Next slide. So I'd like to spend a few minutes just to highlight our body art program. Environmental health ensures that conditions in the facilities and the body art procedures are performed in a manner to reduce injury and illness, both to clients and the artists themselves. And this is done through a plan review of the proposed facility to include the layout, the types of materials, equipment design, employee health practices, and cleaning, sanitation, and sterilization methods. Once the facility is opened, it's then inspected unannounced on a routine basis by the local environmental health specialists. Okay, next slide. Okay, so remember earlier when I said that the exact number of body art facilities is unknown, and this is why. So to give you a brief overview of the evolution of the body art program, you can see here that it began back in 1994 with a law regulating tattoo parlors. And then from 1994 until 2012, the primary focus was only on tattoos, and it was sort of hit or miss around the state for regulation. And then from about 2012 to 2018, we had some counties that began to write their own rules and regulations that not only covered just tattoos, but also piercings. In 2019, legislation was passed that required the Department of Public Health to create a standardized set of rules and regulations that are to be implemented statewide. And then COVID came and the process got put on the back burner until 2021. Funding was provided for licensing for licensing of the artists, and we hired additional staff at the state office for this program. And then the rules, we finally got them finalized this month, and we will begin implementing them over the next 12 to 18 months. Next slide. So here's just a couple of graphics that you can see the visual of the evolution of the county rules from 2012 to 2018. And all the way up until 2018, there were 158 different versions of body art rules all around the state. Next slide.
Can I just say something, Gayla? I think one of the things that was interesting is that we have many rules and regs that we have public hearings on, and we have few comments, if any. I think this had to be redone 3 times.
Yes.
Because there's so much interest, largely on the part of the artists themselves,
That's correct.
in our program rules and regs. So I think that shows you that people have been waiting for this because they know regulation is coming.
That's correct. Yes. Okay, so now that there is a standardized set of rules, there will be consistency throughout the state. The local boards of health will continue to permit and inspect the facilities, and the artists will obtain their licensing through the state office. The body art program will now include tattooing, piercing, and microblading. Next slide. So I thank you for your time and attention today, and if you have any questions about anything I've discussed, then please feel free to reach out.
Now, can I just say one more thing? Sorry about
Yes,
this,
no.
because I know at Fulton, this was of such interest when I was at that county health department. I mean, there's just tremendous interest in this. And I'm really grateful for your work to get this through, because this is a long time in coming, but you could imagine the inconsistency from county to county and how much confusion this causes. And so having a consistent set of rules and regs, as in food service as well, or swimming pools, or did I say it? Yes, septic tanks. It's absolutely critical.
Right.
It's very impressive, Mr. Baxter, and it's an example of how the silent efficiency of public health is never fully appreciated by the government when things don't happen. So every time we eat in a safe restaurant and have a good meal, or every time we, when somebody in our family gets a tattoo or body art of other kind, we just take it for granted. And the reason we can do that is because of how good job you guys do.
Thank you.
Any other comments?
Yes, I'd like to make a comment. First of all, I'd like to commend Mr. Baxter on a presentation. And I have one question, and then, but I'll give my other comment. Every time I go into the restaurant, I look up on the board and I see their score for sanitary conditions and what have you. And I look in the corner and I see Department of Public Health there. So that gives me a great deal of comfort knowing that we're watching over. I don't know a lot about tattooing and all of this stuff, but could you tell me just what microblading is?
Oh, we don't have enough time to get into everything, but I'll give you the 30,000 foot view. So essentially, microblading is when you tattoo the eyebrows, and the way the law was written previously didn't allow any tattooing within 1 inch of the eye. And so the microbladers were able to do that under the supervision of medical personnel. And so it was essentially they were doing tattoos. And so they came and said, hey, can we please be included in this set of rules? Because all we're doing is tattooing eyebrows. And there's no reason for us to have to do it under the supervision of a doctor. And so that was the only concession that was made in the law, was to allow them to do that and group them in with tattoo artists.
Okay. All right. Well, thank you for that.
You're welcome.
Thank you, Mr. Baxter. How about vaccinations for people over 50?
Thank you, Dr. Curran, members of the board. What you're looking at, almost, there you go. What you're looking at is actually a handout that came about at the request of Dr. Cheek. And it was a really timely request because the previous version had been updated in 2019. So like many things during COVID, some things changed. So we were able to do this new handout. It includes COVID vaccines and some updates to pneumococcal vaccines that are available. This is downloadable. It's on our immunization webpage on the DPH site. So anyone has access to it. Dr. Millman is going to highlight just a few of the vaccines and some of the changes that I talked about. But we're also working on a couple of other versions of this, one specifically for pregnant women and vaccines that are available to them that will protect both them and their unborn child. So those are in the works along with many other things communications is working on. But Dr. Millman, if you want to highlight a couple of the vaccines on here.
Sure, thank you, Nancy. So what we wanted to be able to do with this was to be able to provide just a very quick overview of vaccinations that are recommended for adults. I think oftentimes when people are thinking about vaccinations and a whole group of vaccinations, people are generally thinking about childhood immunizations. But one thing that's really important is that adults do get vaccinated, particularly those who are 50 or older, because of vulnerabilities to certain diseases that they may have. So this is something that we wanted to be able to just highlight of some of the vaccines that we would recommend for individuals who are older 50. So people generally will think about things like flu vaccine or COVID. These are kind of recurring vaccines that you that people would get. But there's some other vaccines on here that are supposed to occur at various ages that are less frequent, but still incredibly important. So one of those that we wanted to be able to highlight is the importance of getting the shingles vaccine if you're 50 or older. Anybody who has had shingles will tell you just how painful of an experience that actually is. It's very debilitating. And the problem with shingles too is that it is incredibly contagious. So if you are exposed to somebody like a family, like a young child, or if you are around a young child, somebody who's pregnant, and you have shingles, there is a risk that you potentially could pass that on to that individual if that person has not had chicken pox or been vaccinated at an earlier age. So getting the shingles vaccination is something that's very important to protect your own health as well as to protect the health of loved ones that you may encounter. For pneumococcal vaccination, wanted to just highlight this as well. It's recommended that all adults over 65 get a pneumococcal vaccination. However, there may be some adults who are younger than 65 who would also need to get a pneumococcal vaccination based on pre-existing medical conditions that they may have. And the exact pneumococcal vaccination that would be right for you is going to be dependent on your health condition. So it's important to be able to have that conversation with your healthcare provider to know which pneumococcal vaccination you should get. Flu vaccination is something that's a standard to get your annual flu vaccine. This season in particular, there was a special recommendation that adults who are over 65 should opt to get a high dose version of the flu vaccine if it's available. Depending on what happens in future seasons, we may need to make some updates to this card, but at least this was the case for the past flu season that we were in. And then just some of the other vaccines on here, I'm not going to go through every single one, but these are vaccinations that are very important for adults to be able to get to protect their health, to protect the health of others that they may be around. It's really important that when you see your doctor, you have those conversations about whether it's like if you are an adult, are there vaccinations that you should consider getting depending on what your age or medical conditions are. So we're really happy to be able to have this available, and we're hoping that this will be able to help to improve vaccination coverage for some of these vaccinations among adults in Georgia.
That was excellent. Are there any comments or questions?
I just want to give a shout out. I do appreciate all the team that helped develop this. I think it's very helpful. Had a group of, which I don't usually deal with, is older men that my husband was giving a presentation to, really needed to know about what vaccines they needed to be getting. And they just really all appreciated being able to get this handout and take it home to their families and hopefully to get their vaccine. So I do want to say thank you to all of those that worked on this. It has been very, very useful for me, and I feel like it'd be useful for others.
And one kind of closing remark on this, and this is particularly a shout out to Dr. Mercer as well. When the folks at the OBGYN Society and pediatricians saw this, they said, boy, this would be a wonderful thing to have for kids, for us, as we're seeing the prenatal patients, to give to moms prior to delivery so that they could think about some of the things that they need to do after the baby's born. And so that is Nance is working on that as well, as she said. So that's a preview of a coming attraction. I also want to note that somebody was missing today from the agenda, and that's Dr. Drensick, who's sitting here with us. But our COVID and influenza and RSV numbers look so good. We thought rather than show you that monkeypox has been for now is gone, and we will continue to vaccinate and hope it doesn't come back. And we're doing really well with COVID. I hope it stays that way, and the same with RSV. And although we're still in flu season, never too late for your flu shot. That there wasn't a need for to talk about that. So I think that's progress for a while. And my last comment is, if anything unusual evolves during these last 2 weeks of the legislative session, I'll be sure to write you a note and let you know, particularly good news, hopefully. So that's all I have, Dr. Curran.
Well, are there any other comments from the board about anything?
Dr. Curran, do we need to approve the minutes from last meeting now that we have a quorum?
Good idea. We have a motion to approve the minutes.
So moved.
Second,
I second.
all in favor?
Aye.
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 Great. Thanks a lot, Dr. Mercer. And we do miss Dr. Drensick.
I see her. She's right there.
I was assuming what happened was that she was out buying Braves tickets. The next meeting,
showing her dog, having her at a dog show.
the next meeting is May 9th, and we'll let everybody know whether it's in person or online eventually.
Yeah. And I would hope in person, unless there's some reason otherwise.
Good.
Okay.
Thanks,
or
everybody.
mixed, hybrid. Yeah.
Thanks to everybody.